this is Jay's anatomy, and this is the cardio examination.
For a clinical examination, it is important to have good lighting. The bed should be elevated to 45 degrees. Good morning, sir. May I please examine you? Please get up there. The patient's chest should be exposed. Could you please remove your shirt? Before examining the patient, we need to wash our hands.
Hand washing. Hand washing is a very important and basic form of infection control, preventing iatrogenic diseases in hospitalized patients. There are 5 opportunities for washing your hands when working with the patient. Before touching the patient, before the procedure, after body fluid exposure, after you've touched the patient, and after you've touched the patient's surroundings. There are 2 options when washing one's hands. The first option is with soap and water, and the second option, which is more modern and more commonly used as it is a more practical solution, is the alcohol solution. Ta-da! In this video, we will only be demonstrating the alcohol solution. Yay!
First step is to apply alcohol solution to the hands. Then you're going to rub your palms together. Next step is to clean your fingertips on one side, and the same on the other side. Next, you're going to put your palms facing together and clean your fingers that way. Then we're going to be a bit exotic and clean our thumbs on both sides. Next, we're going to be cleaning our knuckles by rubbing them together on both the right and the left side. Next, we're going to be cleaning our fingertips on both sides. And then our final finishing position to dry our hands.
There are a few important landmarks for the cardiovascular system. They include the precordium, which is the anterior part of the chest overlying the heart, the sternocleidomastoid mastoid muscle, which can be seen if you ask the patient to turn his neck to the right, the clavicles, and the sternal notch. If you move down, we can see the angle of Louis, also known as the sternal angle or the manubriosternal joint, which is where the second rib and the manubriosternum join. At the bottom of the sternum is the xiphoid process. We then have 2 mid-clavicular lines, and on the side is an anterior axillary line and a mid-axillary line.
So for the inspection, I'll first look at general signs. He has the patient has no signs of obesity, muscle wasting, or dyspnea. If I look at the skin, the hair distribution is normal, the color is normal, there are no surgical lesions or signs of any pacemakers. The shape is twice the width and once the depth, and is a normal shape. It's not a pigeon shape, a funnel shape. And for pulsations, you'll look at the apex beat, which is in the 5th intercostal space 1 centimeter medial to the mid-clavicular line.
Hi, my name is Dr. Rano, and may I please get the permission to examine your hands and face for cardiovascular clinical science. So first, we're going to start by examining your hands. So may I ask you to hold out your finger like this? Now we're looking for clubbing. Clubbing is a condition where the soft tissue, there's increase in soft tissue. Please hold out your finger. We're looking for a hyperconical angle, which is an angle that is more than 180 degrees, and your finger looks normal. Another way to examine clubbing is by holding your thumbs together. And we are looking for this diamond-shaped sign between the thumbs, also known as Shamroth sign, and you seem to have it, so we can rule out clubbing and infective endocarditis. And now I'll ask you to hold out your hands. We're looking for a vertical line that forms on your nail beds. We call this splinter hemorrhage, and your nail beds seem to be normal, so we can rule out infective endocarditis again. Next, we're going to look for spoon-shaped nail beds, and these are indicative of iron deficiency anemia. We call this condition cholonchia, and your nail beds have a normal shape, so we can rule that out. Okay, so now I want to ask you to turn your palms around, We're looking for any lesions and nodules. We call these your Janeway's lesions and your Osler nodules, and they are indicative of infective endocarditis, and you seem not to have it, so we can rule that one out. Okay. Moving on to the face. So first I'm just gonna look at the color of your cheeks, and inspect if your cheeks are rosy and does not have a blue tinge, and the color on your cheeks looks normal, so we can rule out a mitral face, which is indicative of infective endocarditis. Then I'm going to assess your eyes, the color of your eyes. I'm going to ask you to please look up. We are looking for jaundice, which is a yellow discoloration of the sclera, and it is indicative of infective endocarditis. Next, I'm going to assess the area around your eyes for any yellow cholesterol deposits, and this is known as xanthelasma, and it is also indicative of type 2 and 3 hyperlipidemia, and you do not have those deposits. Next, I'm going to assess your mouth. Your lips look normal coloration, no lesions. Also, I'm going to ask you to please open your mouth. Now we're going to look inside the buccal mucosa, which is the area inside the cheeks. We're going to look for normal color. The color is normal. And then I'm going to ask you to stick out your tongue. We're looking for a central blue color, and his tongue is perfect and pink, so we can rule out any cyanosis. And then also we're going to look at his teeth. There are no dental caries, so we can definitely rule out infective endocarditis. Thank you for your time.
Okay, we are now going to assess the JVP, which is the jugular venous pressure. First and foremost, the bed must be at a 45-degree angle, and the chest must be exposed, and there must be good lighting. And you must ask permission to touch the patient. So may I please touch you? Thank you. May you please look to the left? Okay. The internal jugular vein pours into the brachiocephalic vein, which pours into the superior vena cava, from which the right atrium receives its blood. As such, the JVP, which is the jugular venous pressure, can be used to assess the functioning of the right side of the heart, such as the pressure of the right atrium. Normality doesn't exceed 3 centimeters, of which if it does, it means that there are several pathologies of the right side of the heart, such as increased pressure of the right atrium, which causes the blood to flow back into the internal jugular vein.
Good day, I'm Ezra York, and I'll be assessing the jugular venous pressure. First, I will ask the patient to look to his leg. So, first we identify the sternocleidomastoid muscle. This is the sternal head, attaching at the sternum, the clavicular head, attaching at the clavicle, and the mastoid process. First, I will observe the highest point of venous pulsation. Then I will place my ruler at the reference point, which is the angle of Louis, which is over there. Then I'll take my other ruler and place it at the highest point of venous pulsation, which is over there, and I will measure 2.5 centimeters, which is indicating a healthy individual and a healthy right side of the heart.
The next part of the examination is palpitation, and we start by examining the patient's pulse. So may I please examine the pulse? So I start by locating the patient's radial pulse. This is found lower or below the thumb, just on the distal radius. I use 2 or 3 fingers to locate it. We can use this radial pulse to determine the patient's heart rate. I count for 30 seconds and then multiply that answer by 2. We expect this to be between 60 and 100. We can also use the radial pulse to determine the rhythm of the pulse, and we think this should either be regular or irregular. And if it is irregular, then we determine whether or not it has a discernible pattern. The 2 radial pulses should also synchronize with one another, and the radial pulse should also synchronize with the S1 beat of the heart, but we'll get to that a little bit later. To assess pulse volume, we use the carotid pulse or the brachial pulse. To locate the carotid pulse, we ask the patient to look to the right, please. And medial to the sternocleidomastoid muscle, we find the pulse. We can use this to determine the volume of the patient's pulse. We can also use the brachial pulse. So can you bend your arm a little bit? We find this medial to the tendon in the antecubital fossa in the arm. We also use these pulses to look for any murmurs or thrills that you can feel. The other pulses we can use are the popliteal pulse behind the knee, the dorsalis pedis on the foot, and the tibialis posterior. There's also the femoral pulse in the groin, but I'm not going to ask to measure that. We can also use this to determine radiofemoral delay, as the femoral pulse and the radial pulse should synchronize with one another.
So next we're going to palpate for the apex beats. Is it okay if I palpate a bit on the chest? Okay, so the apex beats is the most inferior lateral points of your cardiac impulse with every systole. And it's usually around here, but if you can't feel it, you can start more inferior lateral towards the axilla. Just palpate your way towards where it should be until you feel it. Okay, and when you feel it, just localize it with your fingers to where the impulse is the strongest. Okay, so I've identified it in the patient, and now I have to check if it's in the right location. So I start at the suprasternal notch, the angle of Louis, which is the junction of your manubrium, sternum, and second rib. And then you start from your second intercostal space, and you move down, third, fourth, and fifth space. And in this case, the apex beats is in the right position because it's fifth intercostal space and about a centimeter medial from the mid-clavicular line. And then if it isn't in this position, then it's displaced. Next, we're going to check for any parasternal heaving, which could be from right ventricular hypertrophy. So I place the flat of my hand along the left sternal edge, slightly lift my fingers, and there's no heaving in this patient. And lastly, we're just going to check for any palpable murmurs or thrills, and this could be because of turbulent blood flow over the valves. So naturally, we palpate over the areas of your heart valves. So you start mitral, which is about fifth intercostal space, medial to the mid-clavicular line, and then tricuspid, which is left sternal edge, okay, about fourth or fifth intercostal space. And then we look at pulmonary, which is left second intercostal space, and then aortic, right intercostal space. And I don't feel any thrills or murmurs in this patient. The next step is going to be percussion. So is it okay with you if I touch your chest just to percuss a little bit? Okay. I'm going to start with my fingers in the suprascapular notch and then move it down until I locate the angle of Louis. Okay. Once I've found that, I'm going to move my hand into the second intercostal space. I am going to be percussing just inside the mid-clavicular line. Okay. Using the fingers of my free hand, I am going to tap firmly on my finger. As you can hear, the sound is resonant. I will now continue to move my fingers down through the intercostal spaces until my percussion becomes dull, indicating that I have found the inferior border of the heart. Resonant. As you can hear, the percussion has become dull, so indicating that I have found the inferior border of the heart. Now, just to ensure that I have found the correct spot, I'm going to move my finger onto the anterior axillary line and percuss towards the sternum. Resonant, 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 dull. As you can see, the inferior lateral border of the heart is in the fifth intercostal space, which indicates that the heart is of a normal size in this patient.
Hi, I'm Lindsay and I'll be doing auscultation. Do you mind if I touch you?
No, I don't.
So the first of the landmarks that we're going to be looking at are the two midclavicular lines, which stretch from the two clavicles all the way down the torso. Next is the sternal notch, which is over here, and just below that you will find the sternal angle or angle of Louis, and it is in line with the two second ribs. In the precordium, there are 4 areas where heart valves can be found. So the first heart valve that we're going to, or the first area where heart valves can be found is the aortic area, which is in the second intercostal space, which is about here, and just opposite that, on the left side of the chest, also in the second intercostal space, is the pulmonary area where the pulmonary valve can be found. Now, down below is in the 4th or 5th intercostal space,
you will find the tricuspid area where the tricuspid valve can be found. And then below that, where the apex of the heart will lie, which is in the 5th intercostal space, you will find the mitral valve.
Okay. Hello, my name is Amanda Africa, and do you mind if I listen to your heart sound?
No, I don't.
The auscultation of the heart starts in the mitral area, S1 heart sound is revealed, and tricuspid area. Then the S2 heart sound is in the pulmonary area and the aortic area. The sound that I heard is the lap-dap sound. The lap is the S1 and signifies the closure of the mitral and tricuspid valves. It is louder, longer, and slightly lower pitched. The dap sound, or S2, is shorter and slightly higher pitched. It signifies the closure of the pulmonary and aortic valves. S1 is best heard in the mitral area and synchronizes with the radial pulse. S2 is better heard in the aortic area.
Okay, congratulations, Crystal. You are not exhibiting any clinical signs that are concerning or indicative of cardiac in-health, so you are a perfectly healthy patient.
Yay!